Well, in my previous talk, we discussed about diabetic macular edema and how it causes the moderate visual loss in non-proliferative diabetic retinopathy. So let's learn a little more about diabetic macular edema. This is a common cause of moderate visual loss in non-proliferative diabetic retinopathy. What happens in diabetic macular edema are there is accumulation of the fluid. You can see these cystic spaces, intraretinal fluid, and sometimes there is subretinal fluid, which causes accumulation of the fluid in the center. And therefore, since this is the area which is involved in the near vision, the earliest symptom will be difficulty in reading about these patients. The next question is, where is this fluid coming from? Well, it's coming from microaneurysms. We saw early also that loss of pericytes results in microaneurysms which leak. And secondly, there is also diffuse leak, as you can see here in the background from the capillary bed. Coming back to our pathogenesis, the culprit is sustained hyperglycemia, which causes increase in the PKC, oxidative stress, VEGF is released, inflammatory mediators come into play. Hyperglycemia also causes endothelial cell death, breakdown of the blood-retinal barrier, and diffuse macular edema. It causes increase in the advanced glycation product, loss of pericytes, capillary dilation, microaneurysms, which results in the development of edema. So there are different angles we can manage. We can treat microaneurysms with focal or grid laser, or we can treat VEGF with anti-VEGF and these mediators with steroids. So let's see what happens. These are the microaneurysms, as you can see in the center of the ring. So when these microaneurysms leak, they produce edema. If the lipid in the blood are high, they also start leaking and they start depositing at the border of the edematous and non-edematous retina and form these rings, which are also referred to as circinate rings. So by and large, when you see circinate rings, there is macular edema, which is caused by the microaneurysm sitting right in the center of the ring. If you do fluorescein, you will be able to see these microaneurysms very nicely. The second thing is breakdown in the inner blood retinal barrier, which causes a diffuse leakage from the capillary bed. As you can see here, there is some leakage from the microaneurysm, but there is a diffuse leakage in the background. And that happens because of the changes in osmotic pressure, hypoxic stress, as well as VEGF. Now we know there is macular edema. Let's see what is the practical approach in managing diabetic macular edema. I would like to bring your attention. Always remember that diabetic macular edema is the effect. It is caused by hyperglycemia, abnormal lipids, hypoxia. Therefore, though most of the, ophthalmologists will tell you to manage diabetic macular edema, you also have to simultaneously pay attention to the cause. So I generally tell my fellows that it's like a water reservoir. Retina, the macula is like a water reservoir. There is water which is entering, and then we are facilitating the drainage of the water by giving anti-VEGF, laser, or steroids, or whatever. But in case you do not stop the water inflow into the tank, it will just keep coming. So that is why it is important that you take care of the hyperglycemia and metabolic control along with the management of DME. One of the first things, and we were one of the first ones to report, that if you do a good systemic metabolic control, good lipid profile, And here you have to remember that our diabetic patients are very different from those in the West. We have patients who are type 2 diabetics who are not so controlled. Therefore, the guidelines which come from the Western world cannot be straight away applied to our population. Many of our people are not well controlled when they have diabetic macular edema. Their cholesterol is so high, their lipids are very high. So this is to show you an example. This is the patient came at baseline. You can see microaneurysms, hard exudates. We did not do anything in this, we just did the systemic control. Metabolic control, the vision starts improving. This is and some laser to the microaneurysms at a later date. And you can see how these hard exudates disappear and macular edema gets better control. Proteinuria is another thing which we don't pay attention to, and this is the patient with 6 grams protein. Of course, there's a lot of macular edema, but simply giving injections is not the answer. You control proteins along with the thickness itself keeps on going down even before you give any injections. Another question is, do we ever check hemoglobin in our diabetic patients? Because anemia worsens the ischemic aspect of diabetic retinopathy and nephropathy. And anemia develops in overt proteinuria before there is onset of renal impairment. This is the publication we published in BJO. Hemoglobin was 6 gram percent, and you can see multiple microaneurysms here. So this kind of anemia is nutritional deficiency anemia. This is not the erythropoietin induced anemia. And many of our patients have iron deficiency anemia because of the dietary inadequacies. We just treated anemia in this patient, and there was total reversal of microaneurysms, which shows how important it is to look at all the parameters and not simply keep on injecting. So now we come to the next step from eye point of view. So you see a patient of diabetic macular edema, what should you do? I think the step one is you have to find out, does the patient have associated proliferative diabetic retinopathy? Because then the equation will change. For the purpose of this talk, we will assume the patient has non-proliferative diabetic retinopathy with macular edema, and our focus is to manage macular edema. So what next? The next step to do is the OCT. So we used to have a classification by ETDRS about clinically significant, which is not being followed. So when we do OCT, we look whether the edema is involving the center or not involving the center, and what are the patterns of a morphological classification of diabetic macular edema. I'll show you examples. When you do OCT, you first look at the center. Is the macular edema involving the center, which we call CIDME, center involving diabetic macular edema, which means there is thickening of central 1 mm of subfield. And if you see this, this means anti-VEGF are required. The second is non-center involving, which means the central 1 mm is not involved, but there is macular edema. Again, you may try to consider focal laser or just observation for this one. The second is about different patterns of thickening that you can see on OCT. The commonest one is sponge-like thickening, like the sponge absorbs the water. You will have that kind of. Now, this is uniform low reflective thickening, and it indicates the involvement of Muller cells. There could be cystoid macular edema, as you see with the white arrow, or serous detachment, which is neurosensory detachment, and this detachment indicates outer blood retinal barrier failure. Cystoid macular edema generally indicates chronic. If it is chronic, the prognosis may be worse. Another pattern, which is a very important pattern, is to look at the presence of the traction, which we call taut posterior hyaloid membrane or vitreomacular traction sometime. Because if you have the tractional variety of macular edema, you should not be attempting giving injections or laser. Now, this patient you straight away send to the VR surgeon. You can see this is the edge presentation I just did vitrectomy. So, macular edema responds to vitrectomy because the etiology is fractional. When you are doing OCT, slightly more advanced, you can also look at some of these parameters. Like if you focus on the inner layer, is there any disorganization of inner layer, which is called drill? Is there disruption in the outer retinal layer? Or are there too many hyperreflective dots, like you see here, hyperreflective foci? If you have any one of these, you got to treat the patient, but the prognosis will be poorer. So you can, discuss with the patient about the possible poorer outcome. So far, we read that we did macular edema. We saw on OCT whether it was tractional or non-tractional. If it was tractional, go ahead with PPB. If it is non-tractional, you see whether it is center involving, where you give anti-VEGF, and if it is involving the center which has the serous detachment or chronic cystoid macular edema, you actually might consider giving steroid as first line. The second we said, well, it is non-center involving, where we said you may observe, especially if the visual acuity is good, or you may consider doing focal laser. Now let's see if you consider doing focal laser. The moment you decide that you want to do focal laser, it's very important that you do an angiogram to delineate which of the microaneurysms are leaking and which ones you need to target. For example, this patient, we did the fluorescein angiogram, and as you can see, there is this bunch of microaneurysms here, these, which I would like to target, these I would like to target, these, and this. You do not do laser anywhere near 500 microns of the fovea. And when you are trying to do focal laser, keep your burn very minimal, grayish. Don't try to achieve a dense white scar. Burn spot should be about 50 to 100 micron spot size, very gray, minimal, and it's better to have the fluorescent projected, and you will have to invert and reverse it because that's how you see it in the lens and target these microaneurysms. Just remember that if you tend to put scar very close to the fovea, those scars will extend subsequently and will compromise the vision. Therefore, never be too aggressive with treating the focal laser. If you're not confident, you can just observe and get a good metabolic control. Now, we said that if it is center involving, you give injections. I'm not telling you about the protocols because they are available everywhere, multiple studies. But moral of the story is you can decide to give any anti-VEGF. Biosimilars including, by and large, all of them are effective. You can use a fixed dose regimen or PRN regimen depending on the patient profile. The situation comes that you have given 3 injections and there is absolutely no response. Now, this is something you will call refractive diabetic macular edema, which means you have persistent clinically center involving DME with less than 5 letter gains after more than 3 injections have been given every month. What should you do? First is take a pause, re-evaluate. Is there any tractional component which was missed in the first go? what is the status of the macula, and what is the systemic cause. Optimize those systemic factors. Many of these new drugs, like glitazones, they will not allow macular edema to go away. Is the patient on semaglutides and others? Look at that. What is the lipid? Is there anemia? Is there proteinuria? Take care of those factors. You may switch anti-VEGF, and that is the logic protocol T has given, that if the patient is non-responder to bevacizumab, you may try switching to aflibercept or faricimab, or consider brolucizumab if established on anti-VEGF. Steroids, particularly if your patient is pseudophakic and you have anti-inflammatory effects beyond VEGF. For example, you are seeing serous detachment, you are seeing hyperreflective foci, and these are the kind of the patients I give steroids rather than switching the anti-VEGF. You may sometimes consider adding a little bit of focal laser to the microaneurysms, which reduces the injection burden. And of course, if it is the tractional variety, you have to do surgery. We spoke about giving steroids if the patient does not respond after 3 injections. Now, what is the role of the steroids? We do understand and we did see that VEGF is one of the chemical, but there are other chemicals as well which are produced, ICAM, COX-2, TNF-alpha. So while we are targeting the VEGF, there might be patients where other inflammatory components are playing more important role in the causation of diabetic macular edema than VEGF. So keeping on pushing VEGF is not really going to work. So you may have to break the cycle with steroids, and this is how you do. Uh, this is a patient of diabetic macular edema not responding to multiple anti-VEGF. You give 1 injection of DEX, and this responds. Now you have these microaneurysms, which you may give laser because you want to prevent too many recurrences. And if required, you can maintain it on anti-VEGF as well. So, in nutshell, the treatment algorithm is you have diagnosed DME. Is it center involving or no? If it is not center involving, observe laser systemic control. If it is center involving, you optimize systemic control. Anti-VEGF is the first line if it is center involving. Inadequate or anatomical or functional response, you may switch anti-VEGF, add steroids, and of course, you will have to make few changes here and there to take individualized decision whether you want to add a little bit of laser or whatever you want to do. So this is about diabetic macular edema, and we will move on to our next class now, which will be about managing proliferative diabetic retinopathy. Thank you.